Thank you for being here today. My name is Dr. Steve Barczi. I am a geriatric specialist, geriatrician that is, also a sleep specialist, and a neuroscientist that works at the university. And I've done so for over 30 years. And I feel very strongly about getting out into the community and getting a chance to connect with people, share information. In my role as a geriatric specialist, I always kind of tell people, when they ask, what are the specific things I can do to live a long life? And what I tell people is to stay mentally and physically engaged. Wake up every morning with a purpose in life, right? And keep yourself busy enough that you are not sitting on a couch for too long. And all those things will get you a long ways. Today, so I'm wearing my hat as a sleep specialist at the university too. I like to sometimes mix the topics together and talk about the relationship between sleep, our general health, as well as the aging process. And these things are all intertwined. And there are a lot of things that we've learned about sleep over the last 20 or 30 years. And I don't expect to cover all of that, but I will certainly touch upon some of the things that I frequently am asked when I'm in my geriatric sleep clinic or when I'm out speaking either to health professionals or to the community. So, without further ado, I think it's really important that when you are sitting in on a session like this, at the end, that you have a couple of things that you walk out with that may in fact change some of your life rhythm or your day-to-day practice. And so a lot of times when we start thinking about sleep, I think it's important for people to take some scrutiny over their own sleep, as well as maybe their partner's sleep, spouse's sleep, whatnot. And these questions are some great questions to kind of get things going, get us thinking a little bit about it. Many of you in this room maybe are really quite happy about your sleep. Although I bet you there's a few of you who aren't, and that's why you're here. We know that sleep is both what happens at night, but then also what happens with our ability to react to everything around us during the day. And the two kind of go hand in hand, as I'll talk about in a moment. So sleepiness or inattentiveness during the day is also potentially an indicator of things not going well overnight. Lastly, none of us really know what's going on with our own sleep when we are sleeping. But frequently others around us might. And so sometimes some of the hints, some of the information that we can gather talking about sleep may not be coming from ourselves. It may be coming from others around us, bed partners or those who witnessed us sleep, where we might make sounds such as snoring, or we might do funny motions or activities, these kinds of things. I'll try to touch upon each of these areas a little bit during the course of this talk. But I think it's not a bad idea to start with a little bit of myth busting here. And there's all kinds of perspectives out there, things that people believe about the aging process and about the sleep process. So a few of these myths I'll call out right away relate to sleep is going to naturally get worse as I get older. And the reality is, as we age, our sleep can become more, I'll say, fragile. And some people may struggle more with sleep. But I have taken care of many a centenarian who has no complaint at all about their sleep. So it's not universal. But there are some themes, and we'll talk a little bit about what are those themes, or what are those things that do change as we age. Another issue that I'll frequently hear is people might ultimately present to my clinic having struggled with sleep issues for years, if not decades, but never having had those issues attended to. And when I finally ask them, well, why did it take you 20 years to come into this clinic? And they'll say, well, because nobody can treat sleep issues anyway. It's a problem and it's just going to stay a problem. And sadly, that for that person, or those people, that's a myth, because there's always ways that we can improve our sleep. Now, will I take someone who I'm seeing in the clinic who's, in their 80s with some difficulty with sleep and help them to sleep the way they did when they're 20? No. But still help them sleep better. So it's really important. I'm a big fan not just of sleep, but I'm a big fan of whatever lifestyle choices people make that help them to live with less disability, to live as high a quality of life as possible. So when I'm here talking on this, I talk on other topics too, but when I'm here talking about sleep, I say that sleep is an important piece of that pie. And there are certain lifestyle factors which all of you in this room could recite probably that can make a difference. We know that people who are paying attention to or addressing sleep issues, who are staying somewhat physically active, who may be avoiding certain vices or minimizing those vices, things like excessive tobacco, alcohol, and whatnot, as well as thinking about what goes in their mouth every day. Just those simple maneuvers make a huge difference for the people who end up having more disability versus those who are living with less disability. And there's all kinds of research to show that. I cite just one of the articles of a colleague of mine from a few years back. It shows that if people are intentional about those lifestyle factors, you can see anywhere from half to more than half reduction in the likelihood of disability compared to another group that doesn't have that level of attention. So, all the more reason why it's a good thing you're here today. Not only can sleep influence our quality of life, but it also can influence our longevity. And there's a lot of different ways by which that happens, but suffice it to say that if you look at surveys and you look at evaluations that looks at populations of patients who have had good, generally healthy sleep patterns compared to other groups, once again, you can see pretty substantial reductions, upwards of maybe 1 in 5 or more, of individuals who have chronic conditions that limit and there's a term called health span. Has anyone here ever heard the term health span before? Okay, a couple of people. Most everybody in the room is familiar with lifespan, right? That's how much life we have or what our duration is. Health span is the amount of life we have that would be considered high quality life. Okay? So for example, a person who is living in the community, living well, and then some, unfortunate health event occurs, and thereafter they may have another 5 or 10 years of life, but those last 5 or 10 years may not be very good health life. So health span is this thing that most of us are really aiming for, more than strictly lifespan. But health span can be improved upon. And if you look at even things like the duration of sleep, there's a lot of research that has shown that there's a sweet spot. What is that sweet spot? So there are individuals that, and probably in the last 10 years it's become very clear, 6 to 9 hours. So that's a pretty big window, isn't it? 6 to 9 hours seems to be that sweet spot. Much below 6 hours, there's definitely things that we see that go awry. And then you might say, well, why in the world wouldn't 10 hours or 11 or 12 hours? If a little bit of good sleep is good, then why not even more good sleep? Well, this is where there's what I would call scientific confounding going on. Because people who sometimes sleep 12, 13, 14 hours, that's often maybe because there's other health issues at that point. Maybe they're living with a memory illness where they're spending a lot of time sleeping. Or maybe they have other significant health problems that cause them to sleep for big chunks of time in the day and overnight. So that's probably why those longer hours are. It's probably not simply that if I sleep 12 hours, I'm going to shorten my life. But it's probably more the research that's been done about that. But So that 6 to 9 hours does fall within, you know, what everyone's mother used to tell them, right?
8 hours.
8 hours, right. So, now, and I apologize, there's a few graphics here, but I'll walk people through some of these slides. These are 3 research studies that have been done over a span of almost 50 years. Okay, 40 some years. The first in 1976, another one done in about 2004, and the other one done just not too long ago, 2021. And this looks at the prevalence, or how common it is for people to have sleep problems across the lifespan. So just to orient people, on the far left side are like the 10 to 19 years age, and then there's decades, so 20 to 30s, 30 to 40s, all the way up. And the far right side there is in the 70s. And most people probably can notice a little pattern there, that there is an increase in the prevalence of sleep problems as we get older. Some would argue that we probably start to hit our peak somewhere around 40 or 50, and then it may plateau a little bit rather than keep going up, if you look at the graphics there. And then if you look in the little box, you see, well, what are some of those complaints people are bringing up? So by far, the most common complaint people experience is a problem with falling asleep.
But what if you always had that problem and there's physically nothing that you...
Well, good to that, too. So I'll talk a little bit about the genetics and the biology. There's all kinds of involved here, okay? I'm just starting out by giving people a perspective.
Thank you.
So, 40% will have difficulties in falling asleep. And then not too far after that are people who have difficulties staying asleep, or the awakenings during the night. Then there are individuals who might sleep for a chunk of the night, but then they wake up at 2 or 3 in the morning and cannot get back to sleep. That's what we call an early morning awakening. And finally, there are individuals who might not complain so much about the overnight pattern, but they struggle with daytime tiredness or sleepiness, as probably an indicator that maybe the quantity of their sleep is okay, but the quality of their sleep may not be. So this is pretty significant if you consider that we're talking up here in the far right side is almost maybe 40% of people have had sporadic, not every night, not all the time, but sporadic difficulties with their sleep by the time they're in their 70s or 80s. Okay, so what? Well, we do know that from a medical perspective, people who are sleep deprived or have reduced sleep quantity and or sleep quality, there's a host of things that can go wrong because of that sleep problem. And this little, as you're kind of scanning around through this thing, there's some things going on up in the area of the brain, and I'll talk about all these things a little bit more. But we know that when we are sleep deprived, and I'm not going to tell anybody here something they don't already know, when we are sleep deprived, what we know is our emotional state becomes a little bit more labile. Anyone here know someone who was a little more irritable after they didn't have a good night's sleep? We have some important centers in the front of our brain that help us to control our emotions. So put the brakes on some of the things we might think or do. But those brakes are dependent upon, in part, what happens when we sleep. So we may not regulate our emotions as well if we are sleep deprived. We know from work I've done and others in labs all around the country that sleep plays a pivotal role for consolidating our memory. So when we are asleep at night, our brain is active, doing lots of housekeeping. You know, all the things we take in during the course of the day, all the sights, the sounds, the information, it's temporarily stored. But if our brain kept everything from every day, we would hit capacity quick, wouldn't we? So during the nighttime is when our brain solidifies or strengthens some memories and gets rid of a lot of other stuff. I don't remember what I had for lunch 14, 15 days ago. Now, unless I ate the same thing every single day, okay? Or, you know, and so there's all kinds of things that our brain gets rid of during the night, so we're prepared for the next day. Attention, as a, you know, besides memory alone, can also be affected. And anyone here who's ever, you know, familiar with occupational accidents, things like truck drivers who get drowsy and have an accident, you know, that's that inattentiveness. Not only are we talking about the brain, though, we're actually talking about the heart and the blood vessel systems, too. And we've known for quite some time that sleep helps us with control of things like blood pressure and blood sugar and the like. And because of that, it impacts our risk for things like heart attack and stroke. And certain conditions like sleep apnea, which again I'll talk about in a little bit, can increase a person's chances for stroke or heart attack by over 2.5-fold, meaning 250% higher chance of having those kinds of events if you have that kind of problem and it's not being addressed. Even pain. Maybe some of you are familiar, but maybe some aren't. That our emotions and our brain helps us to regulate how we perceive pain. So we can take an experiment, and we have two people, one person who had a good night's sleep, one person who had a bad night's sleep, and we have them both touch the same plate where they get just a teeny shock. And then we're asking those people to rate what their pain level is from that teeny shock. Consistently, those who are sleep deprived or sleep reduced will rate that pain level as much higher than those who slept well. Not only that, but now we start talking about other things like bones. How in the heck does the brain have to do with bones? Well, it turns out that when we are remodeling our bones, there's certain hormones that are very important for remodeling those bones that are dependent upon our sleep. And weight is another example. There's a couple of important hormones that help us with our hunger and help us with our body's thermostat to regulate our weight. Because we don't take in the same calories every day. But our body works really hard to maintain the same weight. Some of those hormones are directly related to our sleep centers and our sleep. So, if I haven't convinced you yet, sleep can be a good thing. Maybe we should take a moment and talk a little bit about sleep. And so, I'll just give you a couple broad comments. So sleep is a reversible level of unconsciousness, but we learned a while back, you know, we spend almost a third of our life doing it. We learned a while back, though, that we used to think of sleep being like you're awake, you're maybe asleep, or you're having coma, okay? But the reality is that our brains, some parts of our brains are more active when we're sleeping compared to when we're awake. And we know that sleep is both a biological rhythm, and it's linked to things like day and night, temperature, and other matters. We also know, as I mentioned, the brain is active, but not only is the brain active, it's not like there's one place, and this is what we've all been hoping for in the field of sleep, is that there's like a switch, and that switch can be on, which is awake, or off, which is asleep. Now, if it was that simple, then science would have figured out the little blue pill that would make everybody happy because they sleep perfectly after they take it. It's much more that the sleep is controlled by many different centers of the brain. And I like to kind of compare it to it's more like an orchestra rather than a switch. And you know how with an orchestra, different members of that orchestra have to do different things for everything to happen correctly. And that's why it has been challenging for some people who live with very significant sleep issues, for us to kind of fully fix that process. Because if we were going to talk about a little blue pill, we'd be talking about that little blue pill that turns these 4 switches on, these 3 switches off, and leaves these 2 switches alone. I mean, that kind of level of complexity. That's why it's been so challenging. You know, and if you came today, I hate to say it, to find out what that little blue pill was, what I'm going to tell you is the best sleeping medicine out there. I will tell you that there is no best sleeping medication. I am sorry to say. But we can talk a little bit more about, I'm not saying that I don't ever believe in any kind of a medication. That's not true. But I'm just saying there isn't one best therapy out there. And then the last piece, which I think is important, is to recognize that although sleep is this biological rhythm, it also can be heavily influenced by behavior. So our sleep behavior can go counter-purpose with what our body's telling us. In other words, if someone chooses to stay up all night long, or maybe they have to for some reason, they oftentimes can compensate. And they can override all those internal bodily signals that say you should be sleeping by the emotions or whatever that's helping them to override. That, in a temporary situation, is probably okay. But obviously people who persistently shorten their sleep because they've got too much to do. They work too late at night doing their work, and then they got to get up too early in the morning to do their other work. And that means that they're shortening that whole amount of sleep. There are downstream consequences from that. So, talking about sleep as a biological or circadian rhythm, everyone here familiar with the term circadian rhythm?
Yeah, my clock is broken.
Yeah. So, the circadian rhythm is actually, we used to think it was a place in the brain that would kind of be the timekeeper for it. But we've actually learned in recent times that almost every tissue in our body has genes that are like clock genes. So it's not just the brain. I like to say the brain is the master clock that synchronizes and organizes all those other clocks all over the body. And there's many things that our body peaks at in certain times. So for example, most people are probably the most alert within the first 2 or 3 hours of the day. Not everyone, but most people. We know that temperature in our bodies is at the lowest point somewhere around probably midnight to 3 in the morning. And we know that our temperature is the highest, predictably, oftentimes between about 2 o'clock and 5 o'clock in the afternoon. Blood pressure, another circadian rhythm. It can be at its peak also in the afternoon. There's many factors, and I just, the picture here probably is a little hard to see in the back, but things like not just the blood pressure and our concentration, but even athletes, physical performance. Anyone know what's the best time of the day? Most world records. What approximate time of the day do the most world records happen?
In the morning?
1 p.m.
It's in the afternoon, about 3 to 5 p.m. Physical performance for most athletes is at their peak in the afternoon. Now, there's always variations on themes, so I don't want to, but generally these are rhythms that we see not just here in the United States, but we see all around the world. And things like bright light outside help us to kind of calibrate our clock. That's why it's so hard around daylight savings time for people. And some people experience the effects of that for not just a day, but can be as far as a week or even 2 weeks later. They're still, their body's just not quite in the new rhythm because someone stole an hour from them or gave them an hour. So what exactly does happen when we sleep? When I was in medical school in the 1980s, I would get lectures that would say, sleep is this mysterious process. It's a black box. You know, it's too complicated for people to understand. I'd hear those things. Well, thankfully, years later, that's not so. We now have a good understanding for lots. We certainly don't know everything about sleep, but we know a lot more. We know, let's kind of move around the circle here, we know that sleep is a great time for brain and body maintenance. Okay? And we regenerate proteins in our brain, we regenerate proteins in our muscles and everywhere else when we sleep. Not only that, but as I'll talk about a little bit later, we get rid of toxins and byproducts in our brain at night. Certain chemicals, certain proteins that actually can accumulate in our brain and cause us harm, like something called beta amyloid with Alzheimer's, is primarily cleaned out of the brain during a certain phase of sleep at night. And so there's a lot of literature now, or a lot of studies now being done looking at that relationship. Immune system. Okay, some of you in this room have probably said, oh, I slept terribly and I got a cold. Well, there's actually some truth or validity to that, because again, just like I was saying, the brain proteins, our immune system also does a lot of rebuilding and remodeling during the night. And when we don't sleep well, certain aspects of our immune system are more depressed. And we are maybe more susceptible towards certain infections and things. The hormones that affect our emotional state, our mood, we've already talked a little bit about that. I'll talk more later. Memory, we'll talk about that at the end. And then other hormonal processes. So things that, everyone here or people hear of growth hormone? So growth hormone is something really important probably in those first 5 or so years of our life, or even maybe even 15 years of life. Growth hormone is secreted almost exclusively at night when we sleep. And if we don't sleep, we miss a night, then we don't get the proper pulse of growth hormone. So that's just one example, but there's many other hormonal examples too, where it's linked to sleep. So how is it that we are able to sleep? And this is a very simple little cartoon or graphic, but it's based on really good science to tell us that there are 2 competing factors that work in all of our bodies during the course of the day. There's this thing we call the homeostatic sleep drive, or sometimes the sleep scientists like to call it process S. Doesn't that sound good? And what process S is, remember, we wake up in the morning, our brain is ready for the day. It's alert. But there are, remember, billions of cells in our skull. Those cells are doing work constantly, and they're doing hundreds of thousands of chemical reactions, kind of like very quickly. Those chemical reactions produce byproducts. It turns out some of those common byproducts that happen with any brain cell functioning and doing its work are sleep promoting. So the longer we are awake, the more those chemicals build up and want us to go to sleep. If we just wake up in the morning and we have nothing to control matters, it really would be only a few hours of alertness before we'd want to sleep again. And then we wake up and then we want to sleep again. And we wake up and want to sleep again. Does this sound a little bit like a newborn? And that's because the newborn has not yet had the organization of their circadian rhythms. So, what our body has done is it compensates. So, as we are accumulating all those chemicals that are going to make us want to sleep, our brain is counterbalancing with things, circadian rhythm of alerting us and compensating. So just like we're getting more of these things that are making us want to sleep, the brain is creating more things to counterbalance to make us alert and awake. And while that percolates along, and you can see that as the day progresses, we get more and more of those sleep-promoting chemicals, and our brain compensates more and more with the alerting mechanisms of the circadian pattern. And so, through the day, we're able to generally stay awake, with the exception of right about here, about 1 o'clock in the afternoon. Does anyone know what 1 o'clock in the afternoon is called in many parts of the world?
Siesta.
Bingo! And there's all kinds of debates as to why, but this is a universal phenomenon across human beings everywhere in the world, that we have this little dip. So, if any of you fall asleep during my talk, I understand why. But eventually, that circadian pattern that's keeping us awake, it drops off. And there's certain things that trigger this to drop off. So you can see that at a point when all of a sudden that alerting mechanism drops off, we've got lots and lots of those brain chemicals that are going to want to make us get to sleep. That's a perfect time for us to fall asleep. And for most people, that falls somewhere between about 9:30 and midnight. 10:30 is kind of average, but and there's biology behind all of this, but this is just because maybe some of you haven't thought about what happens and why do we get to sleep. Now, the triggers that cause that circadian pattern to drop off, there's a bunch of them. Our body secretes a hormone called melatonin. Darkness itself can be a hint. There's certain other important chemicals, and temperature in our body turns out to be important. So all of those factors are the triggers that turn that switch so that all of a sudden our alerting system goes down and we are more likely to get to sleep. Don't stare at this graph too long, but what I will point out is that we have a way of being able to measure if when a person's sleeping at night and kind of measure what phase of sleep they're in, and we can look at the rhythm of sleep through the night. So up in the top here we see a bunch of boxes. Now I'm just going to walk over here for a moment. We're awake, and then at the very beginning of the night we may descend into our first phase of deep sleep. So deep meaning you can see down low there. We get deep sleep in the very beginning of the night. So if you only sleep 3 hours, you're going to get some deep sleep. Our body is good about that. And then after about an hour to an hour and a half, we have our first little bar of what we call REM, or dream sleep. And then you can see through the night we go through these little cycles where now as the night progresses we get more and more of the dream sleep and we get less and less of the deep sleep. But for a young, we'll just say ideal sleep of a young adult, we don't have many times when they wake up. Maybe a tiny little blip, that's about it. As we get older, one of the big things is that we have more of these micro-arousals. Periods where our brain we turn over a little bit, we might open our eyes and go back to sleep. But more of those micro-arousals, and sometimes even more sustained periods. That is one of the things we do see more often. We also probably see less deep sleep as we get a little older. We even see a little bit less of the dream sleep if you're looking at those black bars there. Now, I won't say this is an average older person. This is a generally healthy person who turns out has a couple of other things going on with their sleep. But this is just for comparison and contrast. And you can see in the box to the right there certain things that we know about how aging affects our sleep. So our total sleep time is reduced, but not dramatically. Most people, it maybe drops off by 30 to 60 minutes from age 40 to age 80. So if all of a sudden someone's sleeping 3 hours less, there's more going on than aging alone. Other factors, the efficiency of sleep. Deep sleep, as I talked about, REM sleep. What does increase is blocks of time of wakefulness. And in some cases also more difficulty in getting to sleep. Even, maybe it used to be 5 or 10 minutes, now it's 20 or 30.
What? 5 to 10 minutes, I could never do that. Never.
Well, there are people in this room that probably can.
Our father and our brother.
Okay. So sleep need is another thing to think about, which is our bodies all need it. We talked about why sleep is important. But sleep need across the lifespan from, say, young adult to later adult, you can see the numbers are not nearly as dramatic of a difference as most people would think. The range might go more from 5 to 9 as far as what sleep needs are compared to 6 to 10 or 11. If you take a look at the adolescents and pre-adolescents, that number is much higher. It's probably closer to 12 or 14 hours of need. But there is a subtle difference in our sleep need, but not dramatic. Now, if we start thinking about the factors that might contribute to some of the disruption, there's a lot of factors. So I've kind of organized them in my little graphic here across a couple different categories. So no one in this room, but I've heard that sometimes people will break certain sleep rules and not go to sleep at the same time, stay up late, blah, blah, blah. So there's many different sleep habits and behaviors that I would say can be maladaptive or not optimal for helping us sleep. I'm going to keep moving around the clock here, around the star here, and then we'll kind of touch upon each of these boxes a little bit. Chronic health problems, conditions, and the medicines we might use to treat them. There's a lot of offenders there. Just think about it. If someone's got pain, or they've got bad heartburn, or say, for example, that they start to urinate and they will always empty their bladder properly, so they're running to and from the bathroom at night. These are all examples of health issues that are getting in the way of a good night's sleep. 1 out of every 3 prescribed medicine has a potential way that it can influence either our sleep or our next day alertness. So if I have a patient who I'm seeing in clinic with 10 meds, I can predict pretty comfortably there's 2 or 3 on that list that are going to have a somewhat negative effect on their sleep. The clock. So I've been talking about this clock as if it's like a process that's set in stone. But there are things that can influence our clock. And sometimes that clock can have just a little bit of shift in one direction or another, meaning instead of going to bed at 10 o'clock at night, our body then says you need to go to bed by midnight or 1 in the morning. But if you're still lying in bed at 10 o'clock at night, waiting to go to bed, but the clock is shifted, you will be waiting to go to bed for a while, 2 or even 3 hours. And on the flip side, there are people who, there's a reason for the 9 o'clock news. There are people who by 7:30, 8 o'clock, they're like, okay, it's time for me to get ready for bed. And then there, unfortunately, are people where the clock becomes completely disorganized. And they're awake and asleep and awake and asleep all day and night. And that's tough. Psychiatric or emotional factors can do it. Depression, anxiety, post-traumatic stress disorder are things I deal with on a regular basis with my patients at the VA hospital. But it could be anywhere, really. And then finally, sleep disorders. And we have a sleep textbook that's this thick. And there are about 95 distinct sleep disorders. Okay? Now that sounds overwhelming, but the reality is that about 10 of those disorders are the things we see all the time. And then the other ones are less common. So, when we are preparing for bed, getting back to that habits one, thinking a little bit about, there are optimal things that help prepare our body for sleep. Now, none of these things guarantee us that we will sleep, but the more of these optimal factors together add up, the more likely a person is to be able to transition to sleep more easily. Relaxed mind and body. And again, when I'm in sleep clinic, I'll hear people regularly talk about, my mind gets so active. I just can't turn it off. I lie there feeling tired, ready to go to sleep, and then everything of the day, the events of the last day, the events of the next day, just start churning. It just doesn't. And so the flip side of that is obviously when we can disengage, get to a point where we're not processing so much. A positive association, not just a strong, but a positive association between the bed being a a good place to be. Because there are lots of individuals, if you lie in bed awake long enough, then I can hook you up and prove to you that even if you feel exhausted and ready to go to sleep by, let's say, 9:30 at night, then you climb into bed, but you've been struggling with terrible insomnia for a while. As soon as you lie there in bed, your blood pressure goes up. Your heart rate goes up. Your catecholamines, that is like adrenaline, go up. Because you become conditioned, just like that rat that's in a cage and it goes over to one corner of the cage and it gets zapped. So it doesn't go to that corner of the cage. Or when it does go to that corner of the cage, its blood pressure goes up, its pulse goes up. You become conditioned that the bed is no longer a positive and welcoming place to be. Lastly, absence of regular thought processes about sleep. So there are people out there who will start thinking about, well, am I going to have a good night's sleep by the afternoon? 6 hours before bedtime, they're worried, so starting to worry already. Is tonight going to be the night? Is it going to be a good night? Is it going to be a bad night? And you can get, anyone ever hear the term performance anxiety? A couple more, just speaking, rounding out on the behavioral. Absence of sleep disrupting substances. And I guarantee you, half of you in the room are going to say, caffeine does not touch me. Okay, I guarantee you, I can drink a pot of coffee before I go to bed, even in the middle of the night, and it doesn't touch you. And I can say, no, that's not true. You've developed some tolerance to it, but it still will increase your blood pressure, it'll still increase your heart rate, so it is affecting you. And alcohol and other substances also can have effects. Exercise. It turns out exercise isn't just good because, quote, it makes our body tired. Exercise is good because it influences our temperature curves in our body. Because when we exercise, of course, what happens to our temperature? It goes up. Now, if we exercise right before bed, some people will have a tough time getting to bed. And that's not because of, quote, adrenaline. Because adrenaline only lasts in your body for probably about 45 seconds. If I gave you a shot, it'd be in, it peaks, and then goes away. But the core temperature, your core temperature from your exercise, that's what influences. So some people do have to be careful about when they exercise. Because if they exercise too close to bedtime, their core temperature is too high. And remember I said to you that temperature is one of those triggers that helps us to get to sleep? And how many people in the room here sleep better in a cooler room? Okay, 3/4, maybe more. And that's true. Our bodies do better sleep-wise when the temperature starts going down. The flip on that is, anyone who's ever been in the middle of summer and their air conditioner goes out, and then all of a sudden it's 78 degrees in your bedroom, and you're like, oh, I can't sleep. So temperature can be important. Most people do better with quieter, but not everyone. How many people here like white noise? Nope. Okay, I've seen a fraction of you. Some people do really well with white noise, and there's reasons for that. But generally, darker, cooler, and quieter spaces are better spaces for sleep. I'm going to move along here because I want to be sensitive to time. I'm going to skip through these. These are things that everybody knows. Napping is a good thing, but not too much napping. And I'm going to skip through this, but I'm happy to share some of these slides. Anyone who really wants to be analytical and look at some of the graphics a little bit more closely, I'll pass it along to the person who is the coordinator here. Happy to share any of this information. It's published and out there in the lake. This talks about the nap. Remember I said I'm a fan of naps? Our culture is not. The British Empire, so if you go back, all the countries that have anything to do with the British Empire 200 years ago or more are anti-napist cultures. Many of the others appreciate or even embrace a good nap. This just shows you that, and this is just one research study of hundreds of them that show that if you learn some new information, and then you take a nap. And you're tested on that information later, compared to someone else who learned that same information, didn't nap, and then was tested on it later. We process information stored away better after a nap. One more good reason for a good nap. Now, I've been talking about the behavioral piece, and I think it's important to recognize that if you look at a lot of scientific research for what really helps when people have problems falling asleep or problems with insomnia, there have been literally thousands of studies that have looked at medicines, behaviors, this and that and everything. By far and away, behavioral therapy beats medication therapy in just about every study that's ever been published. But the question is, well, why hasn't everyone who's had a poor night's sleep seen someone who's a sleep psychologist or sleep behavioral therapist? It's because there aren't a lot of them out there. And that's the frustration, is that a lot of people with chronic insomnia, defined as having a problem getting or staying asleep for more than 3 months, that's chronic insomnia. And chronic insomnia is best managed with cognitive behavioral therapy for insomnia, or some variant thereof. There's many variants. Why is that? Because in this room, there's some really, really good sleepers. I could almost set off a bomb in the room next to you and you would still sleep. There are other people in this room that have what I call fragile sleep. They're predisposed to have a poor night's sleep. And it doesn't take a whole lot to tip them from being able to sleep to having insomnia. And many times it's genetic, but it could be other factors too. So you take someone who's a really poor sleeper and then you expose them to something, maybe a life event. They go in the hospital or end up in the ED. Or a loved one runs into a health problem, stressful. In those situations, they may temporarily tip from having a good night's sleep to sleeping poorly. However, many of those individuals will, with time and with removal of that stressor, they'll go back to sleeping well again. But a subset of people will have what I call perpetuating factors. So they tipped to have poor sleep, and then other things kept the poor sleep going. And that's where the behavioral therapies that I'm talking about focus on. They focus on breaking or addressing these perpetuating factors so that a person can come back over to this side where it's better sleep. Now, there's a lot to behavioral therapy. All I'm doing is I'm just telling you that behavioral therapy is very effective. I really don't want to get into today going into all the nuances of it, because we'll never get through the next couple minutes. But there are many varieties of behavioral interventions. For those who are so inclined, stimulus control, sleep restriction, relaxation techniques, mindfulness, blah, blah, blah. There's a long list of them. And there's other things, that pre-bedtime routines. One thing I do emphasize a lot as someone who's not a behavioral sleep therapist, but many people will carry the events of the day to bed with them. And for anyone who happens to be even a little bit of a worrier or a planner, you are so busy all day long, boom, 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 and then you climb into bed, and then you finally have a time to process. And so it's no surprise that some people lie there and process, and yet aren't able to disengage and fall asleep. That's where even just creating a worry list or a worry journal comes into play. 2 hours, not 1 hour, not a half hour, but 2 hours or so before you go to bed. Think about all the things that happened during that day that were stressful to you, or all the things that are going to happen the next day that you need to react to, and just put it on a list. And why do I say that? Because then when you wake up at 1 or 2 in the morning, because we all will, you don't have to start processing those things for the first time, because you've already dealt with some of those things. And this is just a research, this is some of the research, this is a very well-known study from quite a ways back that showed CBT, which is behavioral therapy, placebo, sugar pill, which is the yellow on the top. But the medications, sleeping pills, are the aquamarine, or that bluish. You can see the effectiveness of the sleeping medications is better than sugar pill, but not nearly as good. When we say low is better, not nearly as good as a behavioral. So I mentioned to you that sometimes it's hard to access a behavioral therapist. But all around the world this has been recognized, and so really bright people in places like Oxford and Harvard and Stanford have said, well, if we know a person interacting live with a behavioral therapist can work, can we take some of that experience and convert it into an interaction with a computer or an interaction with a web-based platform? And no surprise, the RCT just means randomized control trial. That's a good scientific trial. And these, on the right side here, these are names of a number of different web-based apps or phone-based apps now that have been shown that are much more effective than placebo or just like, quote, relaxation alone. So for people who do struggle and can't get in to see the sleep therapist, some of these different names of apps, they've all been shown to be very effective. I tell people, many of them are they're fairly nominal cost. So I say, try one, and if that doesn't work, try another. And the odds are you will find something that will be helpful for you. Okay, remember we were going on the clock, around the star here a little bit? A number of chronic health problems are all known to increase the likelihood of sleep difficulties. So just look over on the right-hand side there. People who struggle with depression, about over half of them will struggle with sleep issues too. People who've had stroke for various reasons. And then these are all common conditions. Arthritis. People with chronic arthritis and chronic pain will have some problem with sleep, about 50% of the time. So, and why I bring this up is because sometimes the very best sleeping pill isn't a little blue pill, but it's something to optimize another medical condition. So managing that depression may be the best intervention for the sleep problem. Or better managing the pain. Oftentimes easier said than done, but these are things that may be the real target for the sleep. There's a long list. Remember I said 1 out of every 3 meds? Well, these are just a couple common medicines that we know that can disrupt sleep. Over-the-counter decongestants can have stimulants in them that kind of people don't always realize. Various inhalers can charge our body up. Other conditions or medicines that might be used for asthma or depression, or prednisone, which is one that's commonly used for a lot of body acting up against itself conditions. These are just a small list. And why I bring this up is because sometimes if someone's walking around with 10 medications and they can't sleep, they don't realize the relationship is actually with something that someone is giving them rather than something that's going on with them themselves. And as we're communicating with health providers, pharmacists, or sleep providers, but someone who has a little bit of a perspective on that can go down that list and say, yeah, this one can activate your brain. Yeah, that one can activate your brain. And so it's important to just recognize how meds can have a relationship. There's also lots of things out there that have caffeine in them that you might not always know. Recognize Anacin, Vanquish, Max Strength Midol, all of those have caffeine in them. Okay? Why would that be? Well, many of them are migraine medications, and we know that caffeine can be helpful for migraine. So if you don't read the little fine print, you don't realize someone's popping that pill before they go to bed that actually has caffeine in it. And I've already talked about the circadian rhythms and shifts, so I'm going to jump along here beyond that. But what is valuable to know about if a circadian rhythm is shifted, we have ways of shifting it in other directions. There's something called chronobiotics, okay, not antibiotic, chronobiotics, which are ways that we can shift the internal clock. There are certain medicines and there are certain other approaches. Light boxes. A light box is a chronobiotic. So there are ways, and this is different than insomnia. And so if someone's trying drug A, then drug B, then drug C, then drug D for their insomnia, but it's not an insomnia problem, it's a clock problem, then we're missing the target. We're not going to help. I've already mentioned the brain disorders or brain conditions, and we know that depression, anxiety, dementia, Parkinson's all have unique ways by which they can disrupt our sleep. Again, I'm not going to today go through it, but I'd just like to point out that there are a number of common conditions that interfere. And finally, remember we're moving around that star, we're finally over in this corner where it's primary sleep disorders. And this is probably where a lot of people thought I was going to spend my entire time talking. It's like, how do you treat sleep apnea? How do you treat this? Restless legs. These conditions are, many of them, more common as we get older. As you can see, the prevalence, how common it is in sleep apnea in the whole population is maybe about 10%. But it's almost double that or more than double that as we get older. And restless legs, similar. So these are conditions that are common, and they get even more common as we get older. So I'd be remiss if I didn't make a couple comments about this condition called sleep apnea. Everybody here in the room, I'm familiar with sleep apnea, heads nodding, maybe? Many people are. It is a condition where our pattern of breathing alters as we fall asleep. Some people's upper airways become thicker, or their muscles that support that airway change, and that sets people up for having partial airway collapse. The tongue is a really big, important muscle in our mouth, and it helps us to keep the airway open or not open. And these are just a list of some of the common symptoms that sleep apnea has. The one or two that I like to point out are nighttime urination. I don't know how many people I have cured of their prostate problem by treating their sleep apnea, because sleep apnea disrupts hormones that help hold the urine in. And so if those hormones are disrupted, people urinate more often during the night. That's one example. And why do we care? We know that sleep apnea has a direct effect on blood pressure and on our blood vessels. It influences our blood sugar control. And then it does also have some effects on our level of alertness or focus. So, for all these reasons, we don't like to ignore sleep apnea. But there are different ways we can manage it. Most people in the room here are familiar with the masks, the air tubes, the air devices, the PAP therapies. And those are still probably the primary treatment for about 75%. But there are oral appliances that can be created, you can buy online or you can have from a dentist, that can help in some cases. Certain medications are now starting to be used. Now, the Zepbound or Zepbound and some of these other GLP-1 drugs that you see everywhere now, their primary way by which they probably help sleep apnea is by weight reduction. But surgeries, and then sometimes lifestyle factors. Some people only have sleep apnea when they're on their back. So if I can keep them off their back, they will breathe more naturally. So these are just a partial list of things I use every day in my sleep clinic. And again, too much to talk about in like a short window like this, but it's important for people to know that it's not always about sleep apnea. There are other choices. And lastly, my last comment on sleep apnea is that I don't treat every single person with sleep apnea. I do not. I treat people who have symptoms, maybe sleepiness or excessive urination at night. But I will treat people if they have other health problems that I know get worse with sleep apnea. So if they've got memory problems, heart failure, high blood pressure, frequent urination, I'm going to push to try to treat it, at least to see what difference there might be. Or if someone has a really, really low oxygen level, then I might treat. But yesterday in my clinic, I saw 2 patients who had mild sleep apnea that we decided together, we're not treating this, okay? Because it's probably not. In one case, this was someone who was 94. He had no symptoms. And, the whole point here is I'm not going to help you live a lot longer. and if you're not having symptoms, I can't help you feel better. And it's mild. And mild sleep apnea is very debated about how aggressive we should be treating mild sleep apnea in people over age 70. Okay? I'm going to skip through a few slides. Again, these are things. Make 1 or 2 comments about 1 or 2 other conditions. Anyone here familiar with the term restless leg syndrome? Okay, I see a number of hands raised. It's a neurologic disorder related to the brain, related to the spinal cord, and related to our sensory nerves down in our feet and legs. Best way to describe it is it's just an unusual or uncomfortable sensation. It's in the leg. Some people describe it as kind of a pins and needles. Some people describe it as a creepy, crawly feeling. Some people don't even describe it as a sensory problem, but it just feels like their muscles get really tight. Not cramping, but tight. However it's described, it happens in the evenings. And it can get in the way of us getting to sleep or getting back to sleep. And if we have that sensation and we temporarily move our leg, the sensation very briefly improves or goes away and then comes back. So as I showed you before, this is not a rare phenomenon. What is important to know is there's all kinds of factors that influence restless legs. Caffeine consumption can influence restless legs. Number of medications make restless legs worse. Low iron stores in the body make restless legs worse. Exercise can have a positive effect. And there are many medications available for restless legs. So this is my one little graphic here to say, don't ignore it. Things can be done. Sometimes it's not adding more. Sometimes it's taking some things away to help a person to deal with their restless leg symptoms. Sleep and brain. I have whole lectures I give on sleep and brain and sleep and memory. That a lot of important things happen with our brain as it relates to memory. As I mentioned, we do housekeeping, getting rid of certain memories, keeping other memories. We build up certain brain resources that help us the next day. Hormones that have to do with stress, which are not good for our brain sometimes, can go down as we sleep at night. And I think I've already mentioned most of this, which is there's a lot of information about how certain phases of sleep, deep sleep, consolidates our memory, prunes out the little details. It strengthens certain emotional responses. For the most part, that's a positive. But anyone here who has ever been a veteran or knows a veteran who's struggled with some very, very difficult experiences, unfortunately, those emotions can become hardwired into our brain during sleep. And that PTSD and sleep have this very interesting dynamic, I'm afraid to say. Skip through that. But the last comment I will make is that there are many, many studies that have demonstrated that when our brain does all this work during the day, it has byproducts. It has junk that accumulates in those nerve cells, neurons. And usually it's getting rid of that junk, those nerve cells, during the night when we are sleeping, when brain is undergoing maintenance. If we don't sleep well, those misfolded proteins accumulate more, and they can cause damage to our brain. And there's these things called like beta amyloid and tau and certain other chemicals that are associated with dementia, specifically Alzheimer's, which we know are removed from the body during sleep. And We see this in animals, we see this in humans. And so we're now really focusing a lot more, our memory clinics are focusing a lot more on sleep because of this issue. So, my final slide, I believe, is you've all been sitting here, you've been soaking in information, maybe some things stick, maybe some things won't. But it does come back to some real basics, which are healthy lifestyle can play a really important role, and choosing to be consistent about our sleep patterns and seeking out attention can be really important. Recognizing the relationship between sleep and some of these health issues I was talking about. Thinking about the relationship between medications and sleep, and having someone, if no one has ever done this, having someone take a close look at your list of meds and say which of these could theoretically influence your sleep. And finally, considering sleep as a behavior and knowing that there's some really good resources out there, people and tools out there that'll help if you struggle with getting to sleep. Those behavioral therapy processes I was talking about. And these are just a handful of resources. There's lots and lots of books. If you go on the internet, you'll find hundreds of books on how to sleep better. Not always written by people who have the knowledge base. They may be regurgitating somebody else's knowledge base. But these are a few examples of people who are really bright people in the field of sleep, sleep scientists who've written understandable books. So, for example, and with that, I thank you all for your attention. Now, I do believe we have a little bit of time for questions, but if people need to break away because they've got an obligation, then I'm not insulted if you just walk out the door right now, but I will be happy to respond to some questions. Yes?
This might be a silly one, but is there a better position in general for people to try to fall asleep?
Okay. Did everyone hear that? The question was, is there a better position in general for people who want to go to sleep? It's a good question. By and large, there's a lot of individual variability. So we have people who swear by, I love to sleep on my stomach, and other people say, I can never sleep on my stomach, or vice versa, side to side. What I will say is if a person might have a risk for sleep apnea, then staying off the back is probably a good idea. Sleeping on one side will work better than sleeping on your back for that. Other things like, for example, if people have had heartburn or GERD, we call it, sleeping in a semi-upright position is always going to be better than sleeping flat. So there are specific situations where there might be a better, but if we just look across, if we just look across the general population and say, what's the best sleeping position? There does not seem to be one best sleeping position, unless you link it to a health issue. Other questions?
Talked about our clocks being broken, that we've never been able to just put our head on the pillow and fall asleep. Our older brother and our father, 5 minutes, hit the pillow, they're out.
And you could run a freight train through the bedroom and they would wake up.
Yeah. So, asking a little bit about disruption in the circadian or that clock process. And we know there are individuals that will have these circadian disturbances. Sometimes they're born with them. In some cases, they acquire them. And what we know is, so I'll give you one or two examples. People who've had traumatic brain injuries, been in a bad car accident, or had maybe when the military had explosion. TBI, traumatic brain injury, is very prone to then disturb those clocks. So a person might have had a normal clock and then they have the event happen, and afterwards it's a problem. Individuals, as I said, there's certain families where there's certain genes that seem to disrupt the clock genes that are in all of us. And in these cases, a lot of times we can't fix the clock, but there are actually some medications out there that are like relatives of melatonin. And sometimes those are 10 times or 100 times as strong as melatonin. So melatonin is not the best sleeping pill, but it's a really, really good medicine for clocks. Okay? About 10% of the population will respond to melatonin as a sleeping medicine. But almost 75% will respond to melatonin or some of its relatives that are stronger for treating clock problems. And that's where, when we give the melatonin, is so important. Because it like sunlight, melatonin is the hormone of darkness, okay? And when melatonin hits us, it's telling many places in our body, it is now night. And when we take it in conjunction with what our temperature is, and in conjunction with the timing of when our natural sleep pattern will be, is very, very important. So when people pop melatonin, sometimes 9:30 at night, sometimes 11 o'clock at night, I cringe, because it's kind of like jumping multiple time zones. If someone's doing it at 9 o'clock a couple times, then all of a sudden they do it at 10:30 or 11 o'clock, that's jumping 2 time zones in one night or one day. So you can see how taking the melatonin becomes very important. When you take it becomes very important. And that's where talking with someone who understands this, and these are oftentimes either sleep doctors or psychiatrists, are the two that probably are the most in the know with when you take it, how you take it. So, other questions? Yes.
Then what about all these pills they advertise on TV to go to sleep?
So, yes, so a lot of the over-the-counter sleeping medicines, most of them, probably 2/3 of them, maybe even 3/4 of them, have a product in them called an antihistamine. So people might be familiar with antihistamines because, you take them for itching, you might take them for allergies. They tend to, histamine is a hormone that is one of those hormones that helps our brain to be awake. Remember, I showed you the alerting mechanism, that circadian pattern? Well, histamine is one of about 4 or 5 hormones that charges us up. So antihistamines work to make us more tired. Now, I wish I could say that antihistamines are the solution, but one of the problems with antihistamines are that they also lower other brain neurotransmitters that help us with memory. So sometimes people who have had mild memory problems or more significant memory problems, if they get put on these kinds of medications, they can become more confused. And we try to keep these medicines away from people who are living with dementia, because acetylcholine is one of about 5 really important brain chemicals or neurotransmitters that helps us with our memory. And antihistamines lower acetylcholine. So I do tell people, if a person is relatively young and they're taking some of those medicines, I think the risk is pretty low. As we get older, the risks for side effects of those medicines go up. And so I'll never tell anyone, don't ever, ever, ever do that. But what I will say is the risks are much higher for someone, say, above age 55 or 60 to take antihistamines compared to a 20-year-old. Now, there are other products besides antihistamines, but if you pay attention, some of the other sleeping aids on the market have alcohol. And so, like NyQuil, anyone hear of NyQuil before? Take a look at what percentage of alcohol is listed in NyQuil. Okay? And then there are a couple of other, like, herbal supplements. So valerian, people might be familiar. Valerian is a chemical that is in various plant products, and it's a supplement. And it is a very, very, very distant relative of Valium. But it's not risky like Valium would be. But Those are some examples. There are others on the market now too. I won't go through all of them, but there's less research on some of the over-the-counter agents because who's going to pay for research on those products if they're already out there? Yes, ma'am, there was.
Good presentation, I just want to say. I am a member, a dentist that does sleep medicine, Academy of Dental Sleep Medicine. I get a lot of questions on CBD gummies. Could you address that? That's the new kid on the block.
Yeah, so the question is about CBD gummies or anything, that even THC-based products, other agents that have kind of derivatives of what marijuana has. Now, so CBD is kind of like the part of the ingredient that's a little bit less addicting than, say, THC would be, a little bit less mind-altering. But both THC and CBD have some anti-anxiety properties to them. And so some people speculate the reason why small trials, and there's a handful of small trials that look at CBD and sleep, and there's a subgroup of people who take these CBD products who sleep better. The bigger trials are not yet out, so I can't endorse this. But maybe those people who have a tendency for a bit of an active mind or a bit of anxiety, having something that has some anti-anxiety property in it may be of help. Now the challenge, of course, is like with any medication, there might be some positives and there's going to be some negatives. And so I think we're all sensitive towards how some of the THC and CBD-based products have negative effects on our thinking and our memory. We've known for a long, long time that people who are regular users of marijuana will have a different cognitive trajectory compared to people who never used it. So there's definitely an influence on brain performance. So the question then is, does the risk versus the benefit, especially when something hasn't been very well studied yet, it becomes a little bit of a best guess. So I did not really tell you should you or should you not use CBD. What I hopefully did say is that it is, for all practical purposes, a medication. And it definitely has side effects. And I think one needs to kind of be thoughtful if you were to use it, to be watching very closely for side effects. Might be cognitive, it might be balance. Those would be two things I would watch for. And more to follow, because there are some trials, bigger trials that are in the process right now of looking at things from a very scientific perspective. And even CBD is a mix of a whole bunch of products. It's not one chemical. So, okay, maybe one last question. Yes, in the back.
I could have a cup of coffee followed by a Coke at 1 o'clock in the afternoon. Just fall asleep right away. Why is that? Why did that happen?
It's a good question. And what I'm going to say to you is that if your body is not meeting its sleep need, well, 1 o'clock in the afternoon, though, remember, I did mention, I don't know if you were here earlier, there's a couple things to think about. In the early afternoon is a time when all of our alerting mechanisms just go down a little bit. So many people in this room, if I would have turned the lights off and not spoken, would have drifted. But on top of that natural tendency, if a person is not meeting their sleep need, meaning they're somewhat sleep deprived, they're going to be even more likely to fall asleep. And so then what you're talking about here is maybe your body's sleep need is here. Let's say caffeine of all of its varieties helps a bit, but not enough. So even with that caffeine, it's not fully counterbalancing your body's sleep debt or the need that you have. And you might say, well, wait, I got 8 hours of sleep last night. It can't be that. It's not just quantity, it's sleep quality too. So usually when people are struggling with sleepiness, the very first consideration is they are not meeting their sleep duration or their sleep quality need. And with that, I encourage all of you to find something to work on for your sleep, and have a great day.
Thanks, Dave.